Today's talk, I'd just like to start a little bit of background about our department and the type of breast technique that we use. And then a little bit about how our experience with Align RT evolved, why we got the system in the first place. Sorry, yeah, okay, thank you. Why we got the system in the first place, what we started using it for, and then a little bit about a study that we did where we compared tattoos setup with Align RT based setup, and finally wrapping up with some conclusions and future work. So our department is possibly like a lot of departments that some of you are from. It's a very small one. We have a CT simulator, and it's an 80 centimeter wide bore, which is fairly typical for radiotherapy type scanners. But importantly, and as some of you hopefully will have picked up from one of the breakout sessions my colleague Robin was talking about, you have to be careful when you're using surface guidance to be aware of what your actual scan field of view is, because it's only within that scan field of view that the skin line integrity is maintained. And all the different vendors will have different algorithms for how they then basically stitch on their estimation beyond that. So just something to be very aware of, that if your patient is either too large to fit into that, or because of immobilization and postural aids is actually exceeding that, that if your ROI is then on that region, it could be affected. We're also in the process of commissioning another Vision RT product, Gate CT, on our CT scanner, hopefully for the purpose of doing 4D CT. We have a raise station planning system, and we are, as I said, a small centre with just 2 linacs, both from the Varian side of the fence, one clinac and 1 true beam, shortly to become 2 true beams. And just now, we are lucky enough to have Align RT on both those linacs. And we have a shared file store, which means that we can treat patients on either machine. And if one of the Align RT systems goes down on one machine, it doesn't affect the Align RT system on the other machine. Not that we actually would have to have had any Vision RT or Align RT downtime in our 2 years plus of using the system. We also have an additional offline workstation, which allows us to import patient data into Align RT without interrupting clinical time on the linacs. So now a little bit about our breast technique. It's a pretty standard head first supine. We have a breast board with a standard pitch of 5 degrees with both arms above the head. But if the patient can't manage this, then we would sometimes use a wing board with a vac bag. It's a mono-isocentric technique. By that, the isocenter is placed at or near the superior end of the breast tissue. And that means that if we have tangents and nodal fields, supraclav or post-axillas, then they will share the same isocenter. I think that's a fairly standard approach for many centers. We give a conformal treatment of sorts using field and field in our tangential beams. And traditionally, at least, the initial positioning of a patient was via the use of permanent tattoos. That would be 3 alignment tattoos applied at CT, usually at around the level of mid-breast, or if that wasn't stable, then potentially further inferior. And then at first fraction, this would be then also have a further 4th tattoo applied at the level, at the longitudinal and lateral position of the isocenter. That's to say what we had been doing. In terms of our image guidance, our pre-treatment imaging is effectively a 2D approach based largely on the MV before, coming from the direction of the lateral tangent. And on fraction 1, we would supplement this with an AP or a PAKV, but we would also repeat this if need be, if the MV before was showing a shift greater than 8 millimeters. We would match primarily to chest wall, not to the breast tissue itself. And I appreciate that obviously is something that will affect any system where you're trying to use skin barks or surface guidance for setup positioning. And it's a topic that we have a sort of an ongoing discussion in our department about. But at the moment, this is what our oncologist wishes us to base our primary matching to. During fractions 1 to 3, we'll then confirm, hopefully, that our initial positioning that we've achieved with either our tattoos or ultimately with our surface guidance is within 4 millimeters of the intended treatment isocenter. Or if that's not the case, then hopefully we aim to determine if there's any systematic shift between that position and the intended treatment position. and then we would apply that for subsequent fractions. At that point, our pre-treatment imaging reduces to weekly, and with the intervening setups reliant only on tattoos and shifts. For every fraction, we would do offline review of the MV during images, based mostly on the medial tangent. However, if this showed a discrepancy of more than 4 millimeters, we would resume pre-treatment again on the next fraction. So the point of going through this is that hopefully it just gives you a little bit of background. You can reflect on how this compares with your own techniques and draw conclusions about weaknesses within that system and strengths. The other thing that we do on the first fraction at least is we do 3D transit dosimetry using images from all the treatment fields. And this gives us extra confidence that we've delivered dosimetrically the correct treatment. So with that was what it was. With the arrival of Align RT, this came about primarily because we wanted a slick breath hold solution for our left breast treatments. And initially we only had one system, so on the one Linac. And in order to familiarize ourselves, we started just using it alongside our current tattoo technique. But then we started then slotting it in effectively as an extra fine-tuning step within all our breast setups. We would typically use what Align RT call a treatment capture to check the gross positioning of the patient, and then the fine-tune using the region of interest deltas. We went live with our surface-guided DIBH about 18 months ago, and however, having got used to the Align RT system, and people who were using it were really liking it and seeing real benefit to it, we continued to involve it in all our breast treatments, both free breathing and breath hold. At this point, this is where the sort of unexpected question began to arise. We thought, well, why are we still actually using tattoos? From a practical viewpoint, we were effectively overriding the tattoo positions anyhow. We were finding that Align RT was improving the patient setups and confidence in treatment. It let us look at the complete patient position and in particular the target area, not just the tattoo points. It was letting us deal with rotations effectively before going on to the radiographic imaging, which with our current system and only having a 4-DOF couch was only letting us deal with translational shifts. And also there was the obvious advantage of having a truly effective live monitoring system, which way exceeded anything you might believe you were achieving with a CCTV camera. Also, the effort and time penalty of trying to satisfy both tattoos initially and then fine-tuning with Align RT was really proving counterproductive. There was longer time being spent, and that therefore meant that the patient had to stay in the right position for longer, which obviously then is counterproductive and means they probably can't. And it was an obstacle to staff buy-in for Align RT as well, because the easy option was to blame the new technology for the lengthening of the process rather than taking a step back. The other reasons, we were seeing other centres, both international and private in particular, going tattooless, and we were obviously also aware that for some ladies in particular, the permanency of tattoos can be a significant issue. From a theoretical aspect, obviously alignment tattoos is to 3 tattoos is very limited. It can put the isocenter in the correct physical space, but it doesn't necessarily mean that your target area is positioned correctly relative to that isocenter, particularly for something like mobile deformable targets such as breast. And that's really probably inadequate now for modern conformal techniques. In all cases, we're following this with image guidance anyhow, so it gives us that extra confidence. And so we came to the conclusion that for a deformable external target, such as the breast in particular, the combination of 3D surface guidance and image guidance really was the best approach to both identify the isocenter and to maintain that relationship between the anatomy and the isocenter. The remaining obstacles, the first of these was the fear, because that's how we've always done it, and nobody else is doing this, are they? Well, actually, that's no longer true. The main logistical issue for us was the transferability to our second LINAC. At that point, we only had it on one. And so we decided to wait until we had Align RT on our second LINAC, and then at that point really make best efforts to go tattooless. And also we wanted to conduct more of a formal audit about the comparison between tattoo setup versus the Align setup. So in April this year, we finally got that second system. By the following month, the radiographers had already dropped the isocenter tattoo, which was the least liked by the patient because it's the most potentially visible, being quite high up, and also of the least use in some regards. And over the next few months, the radiographers effectively started ignoring the alignment tattoos. The patients were still being tattooed, but they were just not being set up using them. And this is during this period that we conducted the audit, which I'll talk about in a little minute. And just last month, we treated our first patient without absolutely any tattoos from all the way through. And we've now done perhaps a dozen such patients. And as far as I'm aware, it's all going very well. Unbelievably, the very first patient, the first fraction we did without any tattoos, we had absolutely no imaging shifts after the surface guided setup. I went to the ARIA offline review to observe what had happened for the patient treatment and then thought something had been missed, but it's because there was absolutely no shift whatsoever from the surface guidance. Now, I'm not saying that happens every patient, every fraction, but when you get it right and you really sort of hone things down, I think that's where we could be going. So just to recap on our evolution with Align RT, this is how we started. The old-fashioned approach using tattoos to align the patient, to shift to isocenter before you're doing your imaging. Alongside that, we ran Align RT and we're just monitoring what it was telling us, and we were seeing that it was giving us something pretty similar. We then moved from that to actively using Align RT in the process to fine-tune after our tattoo-based setup. We then basically stopped looking at the tattoos. The patient still had them, but we were ignoring them. We were just going straight to the Align RT system to set up. And I think what also that focuses is that sometimes with tattoos, there might be, dare I say it, the expectation that you just get the patient on the bed and you know what, we'll then manhandle the patient into the correct position with the tattoos. If you start with the basics with Align RT and get the patient to lie down and in the right position and nicely aligned, then actually it should all just float into position very easily in a matter of seconds. So then we move from that to the final step where we've now done away with tattoos completely before we do our radiographic imaging. At this point, I'd like to add too that, as I said earlier, during fractions 1 to 3, we assess how good the correlation is between the Align RT initial positioning and the radiographic confirmation of where we are relative to true isocenter. So if and when we do demonstrate a good correlation there, we also then drop the pre-treatment imaging shifts, pre-treatment imaging as well. So for those patients and fractions, we can then go straight from Align RT to treatment. So just a little bit of detail about the study that we undertook comparing the skin tattoos. This was a retrospective study. All the patients had already received their standard 3 tattoos at CT. The tattoo cohort was business as usual. The Align RT cohort, the tattoos were ignored, and the initial position was based only on the Align RT system. In this cohort, we had 11 free breathing patients. This was to give us a most direct comparison with the tattoo cohort, who were all only free breathing patients. And then also we then looked at the numbers whenever we added in a further 8 DIBH patients to this as well. Exclusions from the study were effectively for best part of a year, we had been, as I say, inserting the Align RT process on top of the tattoos, but we excluded these. These had been subject to an earlier internal audit that we did, but we didn't use it for this most recent audit because we wanted to have a nice clean comparison between tattoos only and Align RT only. And also excluded from the study are the nodal involvement patients with superclaves and post-acts, and that's because we only had literally 2 or 3 patients within the study period. Just to be clear, in both the tattoo cohort and the Align-RT cohort, what we consider to be the initial setup position can also involve systematic shifts that we've identified as being necessary on top of the planning shifts. So for the tattoo-based people, that was equated effectively to just that, an extra shift. And in Align-RT-based positioning, that equated effectively to an extra Align-RT reference surface being used rather than the original DICOM reference from the planning system. That's obviously been verified with your image guidance results. So here's the results that we had. This is for the free breathing patients only, and this is for also only the translational shifts. The root mean square of the long lat and vert shifts that are remaining after your initial setup to whenever you do your pre-treatment imaging and you decide how far off you are from your intended isocenter on the basis of imaging. And with the Align-RT in green, you can see that it's at least as good as the tattoo-based approach, and actually cuts off slightly lower down in terms of the remaining residual shift. Adding into that the breath hold patients, there's practically no change in the statistics, and that just gave us, that was just to tease out if there was. We didn't expect there to be any problem, but that was just to demonstrate it. As I said then, for those patients whose fractions we were able to go straight from using Align-RT into treatment without any pre-treatment imaging, we offline reviewed their results, and this is the 3 translational residual shifts from that, and 98% of those fractions are within plus or minus 5 millimeters. There's one outlier, and that's just to prove it's from a real set of patient data. So as you can see, for all of the individual axes, the vert, long, and the lat, the means and standard deviations are quite, we feel quite pleasing. So some additional comments I would add into that, in that we found our CT process and planning process was totally unchanged from going tattooless. We pondered this for a while, but we still just mark our CT references on the CT scanner, but they're just not tattooed. And this also then allows us to give measurements which we provide to treatment should there be the case of a need to go back to something that doesn't use Align-RT. But we hope that because we now have it on 2 machines and with the separate file store, and as I say, because our experience has been that we haven't had a breakdown of the Align-RT system, that we honestly hope and expect not to have to use this data. The setup is faster. I don't have exact figures for it, but we are treating both free breathing and DIBH patients in standard 12-minute treatment slots. And initially, it started longer than that whilst we got used to the system, but that's what we're currently able to achieve. And something that isn't obvious in that data, that data produced there is obviously only looking at the translational shifts, but what was quite nicely demonstrated in one of the earlier talks was that there's obviously rotations as well, which you don't get to deal with through normal, we only have a 4 degree of freedom couch, and we don't typically do the matching because we only use 2D images. We only do translational shifts. So Align-RT allows us to correct those patient rotations out so that when you go to your pre-treatment radiographic imaging, you're really just dealing with those translational shifts. So in conclusion, we found Align-RT was at least as good as tattoos for initial positioning for tangential breast. And where consistent correlation between Align-RT and radiographic imaging was established, it could be used without any pre-treatment imaging. And it also brings the other advantages of faster and fuller setup, dealing with rotations, live monitoring during imaging delivery, which is a huge advantage, and obviously no permanent skin marks. For our future work, it's like everything, once you start looking into the processes, you find lots of other things you want to review. We want to now review our own radiographic imaging and look at how good that is, the bony anatomy versus soft tissue, and also our imaging 2Ds and whether cone beams is something we should be moving towards. And all this work was done on the basis of a 3 mil, 3 degrees ROI delta tolerances, but we'd like to reduce that now to 2 and 2, which would hopefully reduce the uncertainty even further in our setups. And something that Align RT relies heavily on is the region of interest. We're aware this is something that can be operator dependent. It is operator dependent, but we want to look into ways of trying to optimize and make more consistent those ROIs. So some special thanks to my colleagues, Stephen, Robin and Jane, and also to the radiographers from Genesis Care in Nottingham, who in our early days of using the system were very good at letting us come down and see them, and it was inspirational to see their use of the system. Thank you, and any questions?